Okay.
Yes, please.
Okay, thank you, Doctor. Good evening to esteemed professor, staff, residents from Cipto Bangunkusumo Hospital, and also Prof. Ian McAllister and colleagues from the Lions Eye Institute, Australia. It's a great honor to present this case before such a distinguished audience. Given the expertise in the room, I look forward to engaging with all you all in any discussion that may further enrich our understanding and approach to managing the case of cystoid macular edema in CRVO. For case illustration, this patient is a 51-year-old male who presents with a chief complaint of slowly progressing blurred vision in the right eye over the past month. Despite wearing spectacles, his vision didn't improve and there was no associated visual field loss. His medical history showed no prior known illnesses, and the patient had a history of smoking. Upon examination, we found that the right eye revealed a visual acuity of 6/45 with no better correction or NBC. The anterior segment appeared normal and no iris neovascularization. The fundus examination saw swelling of the optic nerve head, faint rotosity, dull macular reflex, and also flame-shaped hemorrhage in all quadrants. In contrast, the left eye had a visual acuity of 6/9, corrected to 6/6 with the normal appearance of anterior segment as well as the fundus. On OCT imaging done in the first visit, the right eye exhibit a significant macular thickening with cystoid spaces and disruption of the retinal architecture, consistent with the cystoid macular edema. The left eye, however, show a normal retinal thickness with no significant abnormalities. So, what we do in this case, we assess the patient with a non-ischemic type of CRVO of the right eye with a present macular edema. Also assess with dyslipidemia from internal medicine division. We plan to give a loading intravitreal injection of anti-VEGF. In this case, we use bevacizumab, widely available in our center at the time. Also, patient also receives simvastatin 20 mg daily from internal medicine division. The patient was initially seen in November, and then with the visual acuity of 6/45 with the CMT of 810 micrometer, and then the OCT revealed a significant macular edema. Following the administration of bevacizumab at that time, subsequent in November 23, December 2023, and January 2024, by February, after the third injection, the patient's visual acuity improved to 6/15, and the CMT reduced to 304 micrometer, indicating a positive response to treatment. So we have done the loading dose. What would be the appropriate next step? We monitor the patient 2 months post-loading dose at March 2024. There was an improvement both in visual acuity and also the macular thickness. There was also an improvement in the optic nerve edema and faint rotosity. The hemorrhage was also regressing, albeit the patient still complaining the blurry vision. So at this point, we assess the patient with a non-ischemic type CRVO with an improvement in macular edema, and we plan to continue the bevacizumab injection 3 times with a bi-monthly protocol. So here's the OCT after the 4th injection and after the 6th injection. The injection was done bi-monthly at April, June, and July 2024. In August, the patient showed a further improvement in his visual acuity as well as the macular thickness. In September 2024, patient control, and he had no complaints subjectively. The visual acuity were getting better at 6/7.5 at this time, and the optic nerve edema were resolved. The hemorrhage regressed even more, and we decide to monitor the patient monthly. The following month, or 3 months after the 6th dose, the patient came with the complaint of a mild distortion in his right eye vision. Upon the OCT examination, the macular edema was re-emerging. This time with the central macular thickness rise to 346 micrometer, along with the intraretinal fluid appearance. So there was a edema recurrence at the time. We assess the patient CRVO non-ischemic type with a recurrent macular edema, and due to the patient responded well with the previous therapy and the availability of the medicine at the time, we decide to give another bevacizumab injection with also bi-monthly regimen. We done the injection at November, January, and March 2025, and then the patient control 1 week after the 9th dose. This time the visual acuity was improved again to 6/7.5 without any distortion, and also the fundus appear relatively well with a minimal vein tortuosity and also minimal hemorrhage. And this was the latest condition for the patient, and the control was planned to control in 1 until 2 weeks to come. This is the graphs that summarize the history of the patient so far. So regarding the macular thickness, the initial macular thickness was 810 at this patient, and then significantly higher than the normal range, which typically under 250 micrometers. And this suggests the presence of macular edema due to the CRVO. Then after the initial dose, there was a sharp decrease in macular thickness, indicating a response therapy to the anti-VEGF therapy. And the thickness continued to decrease furthermore. But on October, the thickness increased, indicating some reemergence of macular edema. After 3 doses of bi-monthly injection, the macular thickness were further improved, reaching 255 micrometers at the patient last visit. Regarding the visual acuity, the initial visual acuity was 6/45, which is significantly impaired due to the macular edema at CRVO. And the visual acuity could improve consistently and reach 6/7.5 by September 2024, and remain stable through until March 2024, suggesting the visual acuity improvement was maintained. So the CRVO is the second most common cause of retinal vascular disease after diabetic retinopathy. That the most common cause of vision loss in CRVO is macular edema and ischemia. The macular edema happens as a result of the hypoxia-induced capillary permeability after the vein occlusion and a subsequent hemorrhage. For the management of macular edema in CRVO, there are several optional therapies that are available, including anti-VEGF agents such as bevacizumab, ranibizumab, aflibercept, or faricimab, and also steroid regimens such as triamcinolone and also dexamethasone, and also lasotherapy in a limited situation in RVO. And also some advanced approach or management that we can use in RVO, such as radial optic neurotomy, laser-induced chorioretinal venous anastomosis, and also tissue plasminogen activator cannulation that are assessing the occlusion that are happen in the lamina caribosa directly. So there are numerous studies have been conducted to assess the efficacy and also the side effects of various anti-VEGF agents, steroid, and also laser therapies in the treatment of macular edema. However, due to the time constraint, I won't be able to go through all the detail. To summarize, there are several pharmaceutical agents that we can use to treat RVO, such as the anti-VEGF treatment, steroid injection, or implant. And all agents, either the anti-VEGF or steroid, has found could improve the vision and also reduce the macular thickness compared to the same treatments. And also early treatment generally leads to a better outcomes, while the anti-VEGF therapy have a rare adverse effects. The steroid has known to relate or associated with a secondary cataract formation and also an increase in intraocular pressure. There are various protocols for administering anti-VEGF injection, such as loading dose with 3 to 6 monthly injections, followed by PRN or prorata as needed, followed by a treat and extend or TNE, and also followed by bi-monthly injections. And also a direct comparison between agents in different studies is not appropriate due to various in study design, due to variations in study designs, protocol, and also population and also disease severity. Shorter interval between diagnosis and treatment leads to a greatest benefit from anti-VEGF therapy. Additionally, the greatest reduction in central macular thickness or CMT is typically observed within the first month after the first injection, which is also happened in our case. And also, the recurrence of macular edema in CRVO is a common occurrence and has been observed in several studies with varying rates. The rates varies from 22%, and some study show 100% of recurrence of the macular edema. This happen in various type of regimen, anti-VEGF regimen, either it be bevacizumab or ranibizumab or also aflibercept. There's some theory that might explain why this edema occur, such as the inadequacy or decreasing effectiveness of bevacizumab, maybe infrequent in injection if the treatment intervals are too long, or there's a delay between injection, the effect of the anti-VEGF may wear off, that allowing the edema to reappear. Also, the chronic nature of the CRVO itself could cause a long-term vascular damage that leads to an ongoing issue with a leakage and fluid buildup in the macula. This damage can make it difficult to completely resolve the edema, and it can recur even after several injections. Another chronic nature of CRVO may cause the ischemia and hypoxia, which continues to stimulate the VEGF production, leading to new episode of macular edema. And then the theory is the retinal venous collateral formation. There will be a new vessel growth and collateral circulation over time. These new vessels can sometimes leak, that causing macular edema recurrence. Also, the underlying health conditions may also affect the recurrence of the macular edema. So we need to assess the patient holistically, not just focusing in the macular edema, but also the underlying causes of the occlusion of the retinal vein. And also, we need to think about the comprehensive treatment, not just treating the macular edema, but maybe we could broaden our focus by dealing maybe the occlusion itself. And also, some other factors that may relate it to the treatment of monitoring, such as a delayed OCT monitoring. So, by doing that, we are not fast enough to catch the change in the macular thickness and also detection of the recurrence of the macular edema. And maybe non-compliance with the treatment regimen, missing schedule due to some various factors such as patient factors and etc. could result in a macular edema by not being properly controlled, leading to the recurrence itself. To date, there's no consensus regarding the best management practice for the macular edema recurrence. Treatment should be tailored to the individual patients and considering various factors such as treatment protocol, whether it adjusting the interval, switching the agents, or modifying the dose. Some study also suggest that maybe we might consider to use a combination treatment, and managing the risk factors is essential for preventing further recurrence and improving long-term outcomes. So to conclude this case report, macular edema is the leading cause of the vision loss in retinal vein occlusion or RVO. The anti-VEGF therapy is widely accepted as the primary treatment for the macular edema. Recurrence of macular edema is a common phenomenon. Therefore, a holistic approach and tailored management for each patient should be considered to optimize the outcomes. Thank you, Dr. Mario.
Thank you, Dr. Hafiz, for your presentation. It's an interesting case, yeah, about the CRVO, and uh, we will have the Q&A session at the end of this meeting. So hold on. If you have any question about the case, you can write down in the chat column, and later we will discuss after the lecture from the Prof. Ian McAllister. So for the next session, we will have our lecture from our distinguished and also very well-known professor from Australia, Professor Ian McAllister. He is from the Lions Eye Institute, Perth, Australia. Prof. Ian Elster has published more than 160 papers in scientific journals and has given over 180 papers at national and international meetings as an invited guest speaker. So without further ado, I will invite Professor Ian McAllister to give his presentation about the CRVO. Please, Professor.
Thank you, Mario. I'll just share my screen. Oh, there we go.
Yes, it's already visible, Prof.
Okay, can you all see that?
Yes.
Okay, great. So we're going to go through a bit of a run through of central retinal vein occlusion, some of the basic pathophysiology and treatment protocols, and a little bit about, how you treat this, how you manage it, and the things to look out for. So this was originally described 170 years ago. And, I think we have to ask, what have we really achieved in 170 years? Well, unfortunately, until recently, we didn't really achieve much. So it was about 140 years until the first treatment with the laser photocoagulation and the laser treatment for CRVO really didn't show any improvement at all. And then anti-VEGF treatments first emerged about 15 years ago, and they've been through a number of studies. And then if we look at causal-based treatments, the treatment aimed at the cause of the vascular occlusion, the only one is the laser anastomosis one, which relieves the obstruction to venous outflow. And this was further devised or further refined by combining it with anti-VEGF, and we'll go into the reasons for that shortly. So there's still a number of problems we face when treating CRVO, and Mario covered some of these in his discussion. So we don't really know what the inclusion consists of. Everyone thinks it's a thrombus, but that's certainly not ever been proven. And we don't really know exactly where the occlusion is. And we don't know why it occurs at this specific location, and what are the involvement of local versus systemic factors. And why is the macula in RVO so susceptible to edema and ischemic damage? And why do we get inner retinal neural loss even in the absence of capillary ischemia? We don't know what the interretinal sequence of events are in terms of the cytokine upregulation, and it's very difficult to give, accurate prognostic advice. How do we treat the elevated venous hydrostatic pressure? And how do we treat causal pathology? And how do we maximize visual recovery? And what can we do to prevent it? And can we identify people at risk and warn them or treat them prophylactically? So we need to look at the mechanism of visual reduction in acute retinal vein occlusion. And there's really a number of sort of major causes. So the major one is this persistent macular edema. And natural history studies before the advent of anti-VEGF said it takes around 26 to 28 months for the macular edema to resolve naturally. And that is why Mario and Haviz saw this recurrence. You know, once the anti-VEGF wears off, the edema comes back because there's certain factors still at play. And, you know, what he experienced in his case is normal. It's not abnormal. It's not a failure of a treatment. And this is why we have to watch these cases closely, and we have to watch them for several years. And then there's the ischemia, the non-perfusion or reduced perfusion of parafoveal capillaries. And then there's damage to retinal cellular elements in the RPE due to macular hemorrhage. And it's really only the first and potentially the second what you can modify. So looking at macular edema, we know that this is a major cause of visual reduction. Now, it's got several causes. One of the causes, and probably the major cause, is the elevation in venous hydrostatic pressure. This is caused by the vein being blocked. It's a closed loop circulation. That vein is blocked and the pressure builds up because you've got the arterial blood flow pumping in on top of this. So you get stagnation of retinal blood through the retinal circulation. You get extravasation. You get fluid hemorrhage building up. Also, this ischemia causes a breakdown of the inner blood ocular barriers. So the capillaries, which normally have tight junctions, they become leaky. And VEGF does contribute to this. This down-regulates occlusion. And then there's other inflammatory mediators that are released, acutement of macrophages, things like that. So current treatments only address that second set of causes. They don't address the first. And this is why we see this recurrent cycle of leakage. The consequences of chronic CME, well, this is a photo taken before the advent of anti-VEGF, and you can see the presentation and the final visual acuity some years later. You've got macular atrophy, you get closure of parafoveal capillaries, you get this pigmentary plaque, sometimes you get macular hole formation. So there's this balance of forces causing macular edema. You've got the elevated venous hydrostatic pressure, you've got the VEGF blood retinal barrier breakdown. The anti-VEGF can sort of help repair some of that blood retinal barrier breakdown. The RPE pump can sometimes pump out some of that fluid that's within the retina, but it depends on what the intravascular hydrostatic pressure is. The higher that is, the more fluid's going to be pumped out. And this is why the minor ones of CRVOs respond very well to anti-VEGF, and the really high-grade ischemic ones often don't. So looking at RVO and mortality, so this was an older study, but it's found the presence of RVO increases the risk of both cerebrovascular accidents and myocardial infarction by twofold. And it's associated with both hypertension, carotid artery plaques, increased body mass, increased plasma fibrinogen, etc. Now, it's site-specific, this occlusion in the CRVO, and there's two potential locations, and it does depend a little bit on the presentation. The first one everyone thinks it is in the region of the lamina cribrosa. And this was based on original histopathologic studies of chronic CRVOs that had been enucleated years after the event, usually due to the advent of neovascular glaucoma. And they did show, you know, plaques and narrowing there. And then there's clinical studies which would indicate that the occlusion is further distal to the optic nerve head, or further down in the intraneural space. And this is based on different clinical presentations, including optic nerve head swelling. So those that are lamina cribrosa, you don't get a lot of swelling. Those that are retrocribrosal, because you have all of these collaterals within the optic nerve, you get vascular pressure building up and you get more swelling. And sometimes the fact that there is more swelling is a sort of slightly encouraging prognostic factor. So this is in the posterior region of the lamina cribrosa, and this is where this focal area of narrowing is. Now, this is a study that we did at the Lions Eye Institute by Dr. Kang, but a number of us were involved, including Bill Morgan, myself, Da-Yi Yu, and it did show some very interesting changes in the endothelial cells within the retinal vein. Now, venous endothelial cells are very specific. You know, they're not as spindle-shaped. They're more epithelioid in nature. They don't have stress fibers. But the only site in the body where we have found that venous endothelial cells adopt an arterial morphology is in this region of the narrowing in the posterior lamina cribrosa. And that indicates that there's a lot of vascular turbulence occurring in this area, naturally occurring area of narrowing. And as you know from Burkhoff's triad, you know, turbulence creates endothelial cell damage, which then creates thrombus formation and endothelial cell proliferation. And that may be one of the theories of why this is a site-specific disease. So the hypothesis is that you get a thickened sclerotic central retinal artery. There's a common adventitial sheath with the artery and the vein as it passes through the lamina cribrosa. You get compression of the lumen, vascular turbines, endothelial cell damage, and thrombus formation. So it's a combination of an anatomical predisposition at a very site-specific location, and then the influence of vessel wall changes, and then you've also got the other effects of various hemological clotting abnormalities, hemorrheologic changes, etc. Now, should we investigate CRVO? So there's certain conditions have been associated with this, and things like systemic hypertension, diabetes, glaucoma, elevated ESR was one, but just females, and cardiovascular disease, low albumin globulin levels, and high alpha globulin levels. Now, some of these are not all that useful, but basically people at risk are hypertensive, they're arteriosclerotic, they may be smokers, there's an increased risk in diabetes. So if you've got an elderly, hypertensive, patient with cerebral, a lot of vascular disease who smokes, you probably don't need to investigate this patient at all. It's basically all of those conditions just building up at a site-specific location. So how extensive? It depends on their age, their systemic vascular risk factors, whether they've got a previous history of thrombotic episodes, local conditions, glaucoma, etc. And glaucoma may cause some posterior bowing of the lamina cribrosa, which may also impact on this area of narrowing. The indications for screening, well, those with a family history of thromboembolic disease should be investigated. Those with a history of previous thromboembolic disease, a patient who has RVO at a younger age, those that have recurrent or bilateral RVO, or a lack of other risk factors. But as I said, the typical patient you see is not young, and they have cardiovascular disease, they're hypertensive, they may or may not be a smoker, and really they don't need to be investigated. Thrombophilia screening. Now, people do tend to get a bit excited about a retinal vein occlusion because they think this is an abnormal location, but it's not. It's a site-specific disease. So the incidence of thrombophilia in one study in retinal vein occlusion was 5.9%. Now, in normal patients, it was 9.1%. In a DVT, it was 39%. And they concluded that screening is warranted in all with thrombosis at unusual sites except retinal vein occlusion. And this study also has a low prevalence with a high false positive. Now, looking at the studies, these are all of the randomized controlled studies. And most of them, as we said before, address the sequelae of retinal vein occlusion. There's really only two that have addressed causal pathology, and that's the central vein bypass study, and then the laser anastomosis and anti-VEGF study. The natural history, the visual morbidity with CRVO is significant. This is from the CVOS, so this is before anti-VEGF. So most of them do end up with poor vision, less than 20/100 or 660. 34% progress to an ischemic CRVO, 17% will have anterior segment neovascularization. The visual outcome is related to presenting visual acuity, and only 24 recovered one line of vision at 1 year. And that was the natural history. So it's a significant disease, and we do need to treat it. The original CVOS study talked about ischemic CRVOs, and they defined that as greater than 10 disc diameters of capillary non-perfusion. Now, their recommendation was that prophylactic PRP does not prevent iris new vessels. 20% in their controlled group developed iris new vessels, and they felt that PRP should be delayed until iris new vessels develop, and it's more likely to regress in eyes not previously treated. Now, that's a load of rubbish, because basically, how do you quantify ischemia? I mean, it's a spectrum of ischemic diseases from just venous stagnation to complete wipeout of the capillaries. So their 10 disc diameters is neither here nor there. So that study tells us nothing. So, and also their laser PRP was only 1,500 spots, which is reasonably homeopathic for a very ischemic vein occlusion, as you see in the bottom slide there. So both you know and I know that that bottom one is going to develop rampant neovascularization of the iris and neovascular glaucoma, and that needs extensive peripheral panretinal laser. That patient needs 3,000 or 4,000 spots. And if you wait until they develop iris neovascularization, you're too late. The horse is bolted, it's gone. So this is what I'm talking about. This is the sort of laser that you should be doing there for an ischemic vein occlusion. So you can prevent iris new vessels if enough scatter laser is done. But you need to do 3,500 to 4,000 spots, and you need to target all of the areas of ischemia, and you will prevent neovascular glaucoma, which, as we all know, is a really devastating condition. It gives a patient a blind, painful eye. So the studies, so there's multiple studies, and Haviz went through some of these. All of these showed a significant improvement in vision in those that were treated with anti-VEGF. They all got somewhere between 12 to 17 lines of improvement. And this was the, on your right there, this is the Cruise study and its follow-on study, the Horizon study. And at the end of 24 months, that patient had, a couple of lines or 2.5 lines improvement of vision from baseline. So, and they kept that, but, they did need continued treatment. The Crystal study was also with ranibizumab, and that also showed that it didn't matter what the duration was, patients still got an improvement in vision. That bottom graph does show that they still need a moderate number of injections. The mean injections over 24 months was 13. The median was 15. So patients that presented late didn't do as well, which is what you'd expect, but they still got a couple of lines of improvement in vision. They also showed that those with poor vision also got an improvement at presentation. So it really doesn't matter what the vision is when they present, how long it has been there. If their macular is quite edematous, you're going to treat them and they're going to get an improvement in vision. The presence of ischemia at baseline did not affect the visual acuity gains. They're talking about, you know, some ischemia, can be a little bit in the macula, out in the periphery, but again, a frankly ischemic one where there is complete wipeout of the macular capillary vasculature. You're not going to get any improvement in vision, but I would still treat them with anti-VEGF while I'm putting on the pan-retinal laser. So if they present with a wipeout of the capillaries like I showed in some of those slides, my treatment is start with anti-VEGF, but I'm also going to do significant amount of PRP. And once all the laser is done, I'm just going to monitor that patient to make sure they don't develop any anterior segment neovascularization. So the other studies were the Geneva study looking at the dexamethasone implant. And this also showed a good improvement in vision. It did wear off by 6 months. So normally if you're going to treat them with this, you do need to repeat it around the 4-month level. But as you know, there are risks with both glaucoma and also they're going to develop a cataract if they're phakic. So that's the dexamethasone implant. You can see in that wide-angle photo. The studies with the aflibercept, this showed similar degrees of improvement to the cruise study, a good improvement. There are studies which suggest that it may last a little bit longer than ranibizumab, but both of them work very well. The degree that it lasts longer is pretty minimal. The faricimab studies, they've released the data out to 6 months, and this is a non-inferiority study. It did show that the visual gains were similar to treatment with aflibercept. There is a better drying effect, and probably you're going to be able to extend the treatment intervals out a bit longer than with aflibercept, but we've got to wait until the 12, 24-month studies are out before we are really going to get a good idea about that. Faricimab does have some low incidence of intraocular inflammation, and also there's been some reports of occlusive vasculitis, but this seems very rare. So getting back to our original little slide here about the balance of intravascular hydrostatic pressure and the blood-retinal barrier breakdown. So what can we do about intravascular hydrostatic pressure? This was a study that I did on the control group from our original vein bypass studies, where I measured the venous pressure, and I just divided it into low, where it was below arterial diastolic, medium, where it was greater than arterial diastolic, but not yet at arterial systolic, and high, where the venous pressure was up around arterial systolic. So this shows the visual acuity. So those with low venous pressure do pretty well. You know, they end up with pretty much the same vision as what they had at presentation. And this is without treatment. Those with medium have a steady decrease in visual acuity, and those with the very high venous pressure, where it's up near arterial systolic, went blind. When we look at the progression of capillary non-perfusion, again, we can see those with low pressure develop very little capillary non-perfusion, and again, those with the higher pressures develop significant amounts of capillary non-perfusion. In fact, those with the one up here, arterial systolic, we couldn't measure it any further by 8 months because they were essentially blind with neovascular glaucoma. And this is the incidence of anterior segment neovascularization according to central venous pressure over 18 months. And again, you can see that those with low pressure, a very, very few of them developed any iris new vessels, whereas those with the high pressure, basically 90% of those developed neovascular glaucoma over the 18 months. So venous pressure has a significant effect. So what can we do about it? Well, the only way of treating the venous pressure is by diverting retinal venous blood into the choroidal circulation. This is what we did with the vein bypass study. And this is at presentation and again at 6 months. And this is the flow-on study from the original study where we're now combining both of those treatments, the anastomosis with the anti-VEGF. They work in different ways. One addresses the venous pressure, the other one addresses the cytokine-induced blood-retinal barrier breakdown. And here, again, we were able to get this anastomosis to work in about 82% of patients that had it, and they all did pretty well. They developed an anastomosis. We were able to control any complications, but they had a rapid resolution of their venous pressure. And more importantly, it didn't tend to come back. So here you can see a presentation with macular edema. This is the patient at 12 months. And the arrows at the bottom on the indocyanine angiogram are showing the choroidal vessels that the retinal venous blood is now draining into, completely bypassing the central retinal vein. And also, interestingly, we saw some patients that had a collateral optociliary shunt vessel at presentation, and afterwards, all of that disappeared. The venous anastomosis is a lot more hemodynamically significant than a naturally occurring optociliary vessel. And this was their acuity over the 2 years of follow-up. Those with the anastomosis developed a very significant improvement in vision over those, the control group, which were those just treated with ranibizumab alone. So they ended up with about another 10 letters of improvement over the ranibizumab alone group, if they had an anastomosis and ranibizumab. And also, when we look at the number of injections that were required over that 2-year period, you can see at the top line what the anastomoses, that was the control group, the top line, and these were the number of injections that they required in the group after 6 months. And again, you can see in the last year of treatment, so this is from 36 to 48 months, those that were just treated with ranibizumab still required, at least a couple of injections, whereas those in the one where the anastomosis was occurring, basically none of them really required an injection. Why this works? It's probably more because the deep capillary plexus in the macula is much better drained with the anastomosis, reducing the venous back pressure. And that's probably why they get a good resolution of their central retinal, good resolution of the macular edema, and a better improvement in visual acuity, because the venous back pressure predominantly affects the deep capillary plexus, less so the superficial capillary plexus in the macular capillary arcade. And this is just looking at the venous pressure in those with a functioning anastomosis. So we basically just divided this into those with low pressure, which was less than central retinal artery diastolic, and those with high pressure, which was central retinal artery diastolic above. And you can see from the graph there with the blue line, which is the control group, they still have moderately high venous pressure at month 24, whereas those with the functioning anastomosis, which is the orange group, they're basically down to virtually normal venous pressure. So it does work, it does address the venous pressure. So where are we really with central retinal vein occlusion? Well, we've come a long way, really. Pharmacological therapy has been a big improvement. It's unlikely to be the final solution. And, we're getting longer acting agents with faricimab now, but it still only addresses the cytokine breakdown component of the macular edema. It doesn't address the venous hydrostatic pressure. So the current treatment burden is pretty high and long-term. And as you saw with Havis's patient, you had a number of injections, and the edema is still coming back, which is what we know it will do from the natural history. That patient requires ongoing treatment. The central venous pressure remains a major and largely unaddressed component. It's unlikely that it will be possible to revascularize the occluded central retinal vein. People talk about injecting tissue plasminogen activator or some other thrombolytic into a retinal vein, but really, if indeed it is a thrombus causing the blockage, this is the penultimate event in a whole series of pathological events which has led to that thrombus forming. And you may lyse it, but it's probably then going to promptly reoccur. Natural collaterals are slow to develop. Natural history studies show that they take anywhere between 12 to 18 months to develop, but they're also hemodynamically inefficient. The cause and propensity for individuals to develop CRVO remains obscure. There are considerable local factors involved, and these do have an effect, but there's also a lot of systemic factors which act on the vessels. It's possible to create alternative pathways, but more work needs to be done to improve the predictability and success rates. The laser anastomosis technique, whereas I do it, certainly a lot of other people don't. You require a specific laser. It needs to be a high power density laser. You need to follow these patients very carefully. And it's much easier just to keep sticking needles into patients' eyes. What actually happens in the retina is complex, and it's certainly not solely limited to VEGF. There's another of other cytokines that we know are upregulated, a lot of inflammatory cytokines. And neurodegeneration commences early, and we don't really understand why, but to get a long-lasting and stable visual improvement, we may need to sort of work out ways to treat this and limit further progression of this in our management. So we have a lot of improvements, but there's still ways to go. Sorry, they're just a couple of extra slides. I think that's probably about it. So I think we can go into the next phase and any discussion.
Okay, thank you very much, Professor Ian McAllister, for your nice presentation. Very eye-opening presentation that we could learn from you, Prof. And now maybe we will move to the Q&A session. So I will invite all the participants and also to Dr. Hafiz for the case presentation to type in the chat column, or if you want to directly open your mic, you can also raise your hand. Please, to all the participants, raise a question if you have any question.
Thank you, Dr. Mario.
So before that, I will maybe start with my question, Professor
Dr.
McAllister.
Mario.
Yeah.
Dr. Mario.
While we're doing that,
Let's say
Mario.
chorioretinal.
Yep. So you're breaking
Prof?
up, Mario.
Okay. Yeah, sorry. I just want to ask about the laser-induced chorioretinal anastomosis that you use for the CRVO, Prof. Could you please explain about the laser you use, and also the how do you perform the laser-induced anastomosis, Prof?
It needs a high power density laser. So the laser we had was built specifically for this, went up to 6 watts. And I typically use around somewhere around 2.5 to 3 watts. A small spot size, 50 microns, 0.1 of a second. But really, unless you have a proper laser, if you try it with a standard laser, you will just create intraretinal neovascularization, which can lead to scarring and fractional retinal detachments. So it's not something to do without a proper laser. It's a little bit, the treatment was started, we developed this prior to anti-VEGF, and at that time, the retinal community was fairly excited about it because, we didn't have any other treatments. Anti-VEGF came along. And look, anti-VEGF gives an immediate improvement in vision. It does work, but as we all know now, it's a massive treatment burden for many patients. It's very expensive, and it's not curative. The laser anastomosis is curative, but it needs to be done carefully. If you don't do it carefully, you end up with a whole series of problems, and you need to follow these patients very carefully. I've been doing this for many years now, and in my hands, I can get a success rate of about 82%. Not everyone will develop anastomosis, but once they develop anastomosis, it stays there forever. So look, it does work, but it's not a treatment for everyone. And I would counsel people against trying it unless you have a proper laser and you're experienced in how to do this. You will run into problems.
Okay. Yeah.
Now, I'm just been looking at the questions here. There is a question from Dong, and
Yes.
Dong asks, when is it safe to do panretinal laser in someone with extensive intraretinal hemorrhage? And that's a really good question, because often, as in the case that Hafiz showed, we do see extensive retinal hemorrhage. So what I do with those cases is to treat them with anti-VEGF. I don't start the laser. If they've got extensive hemorrhage, you can't do a fluorescein angiogram. And I often like to do that just to see how much ischemia is there. So I will treat them for a few months with monthly anti-VEGF, wait until the hemorrhage goes, then I can assess them with a wide-angle optos, or take multiple angiograms out in the periphery, see how much ischemia is out there, and then I'll do the laser. So I treat with anti-VEGF until the hemorrhage goes, and then I treat them. if you treat on top of hemorrhage, you'll get a superficial retinal burn that will actually burn through the internal limiting membrane, and then you're more likely to get retinal epiretinal scarring and proliferation and problems like that, or even create a retinal hole.
Okay, how many injection for the anti-VEGF you usually do, Professor McAllister?
So it depends on what I'm planning to do. So I like to measure their central venous pressure. And the way I do that is to just look at the optic nerve with my, 60D lens, on the slit lamp. And then with one finger, I'm pushing on their eye while I'm holding that lens. So I push on their eye and I keep pushing on that eye until I see the central retinal artery start to pulsate. So that's arterial diastolic. And I look at also when the vein collapses. Now, if it hasn't collapsed by the time that the artery starts pulsating, I'll keep pushing on it. And if it collapses, when the artery collapses, that's up around arterial systolic. Now, that's got a bad prognosis. If it collapses well before arterial diastolic, before the artery starts pulsating, they have a much better prognosis. So I'm fairly happy with those ones because I know they're not going to need a lot of anti-VEGF. They're much likely or more likely to get a good response fairly quickly. And, they're not likely to be one of those patients that's on anti-VEGF forever. Now, some of them start off with low venous pressure and then over the next 3-4 months might develop the pressure to be a higher pressure, but you'll see that patient developing more intraretinal hemorrhage, more cotton wool spots, things like that. So it's a dynamic situation. If they're really high pressure and they've got extensive hemorrhages, again, I will treat them with anti-VEGF because that will stop them developing anterior segment neovascularization. And I'll do that as long as it takes so that the hemorrhages have cleared enough that I can do an angiogram and see how much ischemia is there. And then I'm going to start my pan-retinal laser, and I'm still going to keep covering them with anti-VEGF until I've completed that laser. And then I'm happy that, happier, that they're not going to develop this really devastating consequence of neovascular glaucoma. They're not going to see much because usually they've got their macula wiped out, but they're going to retain a comfortable cosmetic eye that's not going to require a lot of treatment. So it's variable.
Okay. Yes. Do you also do the loading dose, Prof? How many loading doses do you give for
injection? Yes, I tend to do a loading dose because basically I want to get the edema and the hemorrhage out quickly. But if they're a really ischemic one that I'm worried about anterior segment neovascularization, I'll keep treating them every month. Becumazevib, Avastin, lasts in the eye 5.3 days. That's its half-life. So, it wears off quickly. And that's why, if you've got a patient that it's high risk of anterior segment neovascularization, you need to keep treating them every month until you've got your laser on. Basically, you're starting to tail off the anti-VEGF as that patient is naturally dropping their venous pressure and they're developing some intraneural collaterals, or they may develop an optociliary shunt vessel, or whatever caused this obstruction in the first place is starting to naturally regress.
Okay, thank you, Professor.
So I don't. There's a question from Dr. Kong here, and
from
So he's asking, do I order angiography on all my CRV patients? No, I never do angiography when they first come in. I'll do it later on when the hemorrhages have resolved. And that's when I'm looking to see how much ischemia is there and whether I need to put some laser on in addition to treating them with anti-VEGF. If they've got a lot of ischemia out in the periphery, I'll treat some of that with anti-VEGF and laser. So, you know, I don't see the point if there's a ischemic retina there that's producing VEGF, it should be treated. Any other questions?
Excuse me, Prof. Ian McAllister. How about your view about the radial optic neurotomy in treating the CRVO, Doctor? Prof.
Look, that was a treatment that was popularized, 20 years ago. I have not seen any studies about that in the last 15 years. There's been a number of reports of some fairly devastating side effects from that. Hemorrhages, damage to the retrobulbar vasculature, retinal detachment, scarring, things like that. The original hypothesis was that by incising the scleral ring, you might magically allow this lamina cribrosa to spring open and release the pressure on the central retinal vein. And that's not how it worked. It basically was a surgical creation of a anastomosis. That's how it worked. And that only occurred in 30-odd% of patients. And so, these patients require a vitrectomy. The needle goes in, or the MVR blade goes in. There are risks of hemorrhages, retinal vascular damage. And the problem also is that, basically, if you're doing a vitrectomy and it doesn't work, and most of them didn't work, 70% of them didn't work, you've got a vitrectomized eye, and your anti-VEGF, whichever one you're using, is only going to last a third of the time that it does in a non-vitrectomized eye. So you've created more problems for both yourself and your patient. The advantage of using the laser one is that it's just done as an outpatient, completely painless. You're not required to give that patient an anesthetic. There's no surgical complications from it. Sure, you do need to follow them up. They do have a risk of aberrant neovascularization from the laser site, but that neovascularization is exquisitely sensitive to anti-VEGF. It's very easily controlled.
Okay, Dr. Please, does that answer your question?
Yes, Doctor. Thank you, Prof. Ian.
Yeah. Okay, any other question from the audience? Yes, Prof. I just want to ask about that you mentioned about the low venous pressure give the better prognosis for the patient, Prof. So how do we can lower the venous pressure in the patient? Is there any tips and tricks, or what can we do to have a lower venous pressure?
The only way of lowering it is with this laser anastomosis procedure. So unfortunately, that's the only way that's been proven to lower it. And that's been proven in a randomized controlled study. As I mentioned before, I like to measure it, and I don't actually measure it formally with an ophthalmodynamometer. I'm not interested in the exact pressures. All I'm interested in is what that vein is doing in relation to the arterial pressure, whether that vein is staying open through the whole cardiac cycle, or whether in part of that cardiac cycle, that vein is closed, or that vein is closed during the complete cardiac cycle. So that just gives me a bit of an idea of what the prognosis is, what I can expect from this patient, and it gives me a bit of an idea of how to monitor whether there is some recovery occurring.
Yes, thank you, Prof. McAllister, for your answer. And I think because of time, we already have we already reached the end of the time. So I just want to thank you so much for Prof. Ian McAllister that for your willingness to share with us about your knowledge, and also very eye-opening presentation for us as an ophthalmologist in Indonesia. We do hope that we can learn from you that already given the lecture tonight. So is there any announcement from Dr. Firna, Dr. Adiela, or Prof. Bill Morgan about the series of this lecture series?
No, Dr. Mario. We'll always
So,
do that, yeah, every
yes.
month. Every month, yes. Thank you.
We look forward.
What is the next topic, Dr. Firna?
The next
for
topic,
the
I think from,
series?
I think Dr. Diela will,
Yeah, Dr. Firna, next topic will be about retinopathy of prematurity.
ROP.
Yes,
So for pediatric ophthalmology.
yes, correct. Yeah, it will be next month. We will give the flyers next month.
Okay, thank you, Dr. Dela, for your information. Are any comments from vitreoretinal division staff and Sipta Mankusumo, Dr. Ari Jati? Maybe do you have any comments or speak? We want to speak about our topic today. Any comments?
So yeah, thank you, Dr. Maria. So I don't think I will have another comment. I think Professor McAllister has given us a very nice and a good lecture. I think it's give us some new perspective about how to manage the CRVO, and I would like to appreciate and thank you and big applause for Professor McAllister. Thank you very much, Doctor.
Well, thank you very much for inviting me. It's been an honor. Thank you.
Yeah, thank you, Dr. Mario.
Thank you, Dr. Ari. Any more comments for
Mario,
maybe
probably last
Dr. Dela? Yes.
before we close the meeting, probably we need to take pictures all together.
Oh yeah.
Yeah.
Yes. Yeah, we can turn on our camera and we will have screen capture of the picture. Yes, please, Dr. Tiara. Screenshot the camera.
Thank you, Doctor. Thank you, Professor. I would like to thank you for joining to this lecture. I will now begin the photo session. Please give us your best smile. 1, 2, 3. Next slide. 1, 2, 3. Okay, that would be all. Back to Dr. Mario. Thank you.
Thank you, Dr. Tiara, for your screen capture. Yeah, we have come to the end of this meeting. Thank you very much for your time, Professor McAllister, and also Prof. Bill Morgan, Dr. Firna, Dr. Adiela. We hope that this series will be continuing and give many more benefits for our ophthalmologists in Indonesia and also in Australia. So I will conclude this meeting. Thank you very much and have a good night. Thank you. Have a
Baik,
good night.
Dok.